Hot flashes, night sweats, and mood swings are all symptoms of menopause or perimenopause. They can be intense and tough to deal with, but there could be some relief. The FDA recently changed guidance on hormone replacement therapy, now removing old black box warnings. So to break down the facts, Dr. Nita Bijoor is joining us live. She's a family and lifestyle medicine doctor here in Greenville from Oakview Medical Associates. So thank you so much for joining us
Thank
today.
you for having me, Carrie, as always.
So let's first explain what is hormone replacement therapy for someone going through menopause.
Wonderful question. So perimenopause is the phase of our life where our ovarian function declines in women. That can go down to about 3 to 10% by the age of 40. And between 40 and 50, our hormones are fluctuating. Just like in puberty, hormones are rising. In perimenopause, hormones are declining. And finally, when you have 1 year without cycles, that's called menopause. So you achieve menopause, and then the time frame after menopause is called postmenopausal period. So this entire time frame is what we call menopausal transition. It's not a disease, it's just a physiologic state, just like puberty is. However, we really go through a lot of symptoms as women, which have been completely under-recognized, but now that's changing.
So what is the hormone replacement therapy?
So hormone replacement therapy is basically replacing or optimizing the hormones that are declining. The ovaries make a majority of our estrogen and progesterone, and almost every tissue in the body has estrogen receptors. So when you can imagine, if the hormone declines, those tissues lack estrogen, and then we see all the effects of that and all the symptoms that come out with.
So that's why you might have night sweats or hot flashes or something like that. Yes,
hot night sweats, hot flashes, mood swings. You know the term, fun fact, hysteria comes from the Latin word hystra, which is uterus. So it was the emotional outburst that women went through because of uterine changes. And now we call it hysteria or hysterical, referring to that with a negative connotation about mood and mental health. But it comes back to addressing women's health appropriately.
And I understand you can have this hormone therapy as a pill or a patch or different ways like that. Can you
Lots
explain?
of ways to replace. So what we do is we sit down with the patient, evaluate their history, check blood work if we need to, really look at the risk factors, and then when we talk about replacement, there are creams, gels, patches, rings, injections, pellets. There are many different ways of replacing.
So you would recommend it for possibly both perimenopause and menopause?
Absolutely. Perimenopause, that's a very good discussion to be had with the patient. If the patient is struggling with symptoms, foggy headedness, mood changes, fatigue, frozen shoulder is actually related to estrogen decline.
What is that?
That's a stiffness of the shoulder, where your shoulder just becomes really stiff, and very painful condition that now has been linked to estrogen declining. So once you start replacing those hormones, immediately a woman feels like she has her life back again.
Yeah. Are there any people who should not try this?
Yes. So there are some absolute contraindications. If we have an undiagnosed vaginal bleeding, we don't know why the woman is bleeding, we need to evaluate that first. If there's an active cancer, an estrogen-sensitive cancer, maybe breast cancer or any other form of cancer. Also, if there's been a blood clot, a leg clot, a lung clot, or a stroke, or heart disease, or heart history, we want to get that evaluated. If there are certain clotting disorders, there are some genetic clotting disorders where we don't use hormones. All of this, of course, is with shared clinical decision making and collaborating with the specialists, whether it's the hematologist, oncologist, cardiologist. We as primary care physicians are really trained in making sure we have that patient's informed decision and touching base and looking at their risk factors. We don't want to do any harm, so we want to replace it if the person is healthy and needs it.
What have you seen with your patients? Has it worked?
Oh, beautifully. So let me tell you, when I graduated residency in 2000, that was the time when this WHI study came out. And basically, we were told, we had patients on hormones. We were told, just stop everybody on hormones because it can cause cancer, it can cause heart disease. Well, now, 20 years later, they look back at those studies and recognized that those studies had a lot of flaws. Firstly, the average age of the women was 62. That's 10 years after we actually go through perimenopause and menopause. And they already had heart disease. So though they cause a lot of fear in patients, luckily I came out at a time when a lot of other physicians were not even prescribing, and I listened to patients. I sat down with them, and that kind of prompted me to even go into this field and learn about women's health. So I'm extremely passionate about it, and I've had really great successful stories of women where they have their life back, they have their focus, misdiagnosed as ADD, but once they got on the right hormones, their focus is better, they are more, they've built up lean body mass. all of this is in context with lifestyle management. So nutrition, sleep, exercise, stress management, all of that comes first. And then if we need to optimize with hormone therapy, it's a win-win and a game changer.
So let's say you had breast cancer in the past. Would you be eligible? Would you recommend hormone replacement therapy?
It depends. So if the woman is struggling and the breast cancer has been completely treated, and nowadays the survival rate of breast cancer and the treatments are very successful. So if everything's good and I partner with the oncologists, we have several good facilities in our area where we can collaborate with the oncologist and years down the road say, okay, this person is safe, we are monitoring, we're getting negative mammograms. Is it time to talk about replacement? Like I said, it's most effective in the first 10 years of menopause. So you don't want to start someone in their 75 and 80s on it. But if the patient wants it, if there is enough benefit from it, risk versus benefit, we're always looking at that as physicians. Then it's a conversation to be had.
All right. Well, thank you so much for joining us. I know a lot of people are curious about this since a lot of the data has changed.
Very
your viewpoint
exciting
on it.
Yes.
So thank you for joining us.
You're welcome.
All right.